Rashid asked me to sort of highlight one of the things we've done here in the Department of Emergency Medicine, looking at the system of care related to acute care, but specifically related to critical illness and injury. So I think we're going to have a tag team presentation here where I'm going to talk a little bit about this evolving interface of emergency medicine and critical care in the U.S. health system, and then Ben's going to talk a little bit about what we've done here at the University of Michigan to sort of do some disruptive innovation related to that interface. So just a few disclosures. The only thing here related to industry is I do get some equipment support from Physio Control for animal research and clinical research related to cardiac arrest resuscitation. So here's my outline. I'm going to talk a little bit about the origins of emergency medicine and critical care, just because I think it's helpful to reflect back on how these areas of specialization in medicine came about to better understand why we're in the situation we are right now. Talk about the interface between emergency medicine and critical care and how that's evolving over the past few decades. And then I'm just going to introduce or tee up the U of M approach to that interface, and then Ben will talk a little bit more details about what our experience has been over the past few years. So with that, you may or may not know that the first ICU, at least the guy that got credit for the first ICU, was Bjorn Ibsen, was created in 1952. So over 60 years ago, sort of the birth of critical care occurred, and that's this picture here. I don't know if I can get the cursor to go. This is the picture of the hospital it was in, and then the circle. Do you have a pointer? No. That's fine if we don't. The circle is where that first ICU was supposedly housed, and he published a paper on their experience in 1952 with the first ICU. They called it Work in an Anesthetic Observation Unit. So he was an anesthesiologist, and the reason that critical care developed in his hospital was related to anesthesia and post-operative recovery of patients and managing those patients that needed ongoing critical care. But that wasn't the only reason they had, and they had, even at that time, back in 1952, he mentioned emergency care. So basically, the intensivist therapy unit for respiratory and circulatory insufficiency and some emergency work on newly admitted patients. So the newly admitted critically ill patients would actually go to this ICU that was created in 1952. Then in the U.S. experience was really led by Peter Safar, and the first ICU in the United States was at Baltimore City Hospital, which now is part of the Hopkins Medical Center. In 1958, Peter Safar created the first ICU in the United States, and a lot of this was driven by, one was the polio epidemic, but two, the transition to positive pressure ventilation. So going from the iron lung to endotracheal intubation and positive pressure ventilation, this was a therapy that required intensive monitoring and adjustment of therapy. So, and this is a picture of 3 patients that were totally paralyzed and given artificial respiration with intermittent positive pressure ventilation back in the 1950s. And they've actually published their experience over 2 or 3 years. And this is just some highlights to give you a perspective 60 years ago of what critical care was. So you can see most of their patients were post-operative patients. Again, Peter Safar was an anesthesiologist. But they had a significant number of trauma patients. So right there's their trauma patients over the 2-year period, or 3-year period between 59 and 61. And then they had a lot of medical patients. And if you look at those are the same critically ill patients we see now in the emergency department. Pulmonary edema, pneumonia, coronary occlusion, poisoning, stroke, seizures, sepsis, COPD exacerbation. So you'll see when Ben talks about our emergency critical care experience, it's really the same patient population. They had a pretty high mortality. If you can see on the bottom there, the medical patients, 96 out of the 267 died. So it was a high mortality rate in that patient population. And then they talked about in this paper their whole system of care, their whole hospital system of care, how the critically ill patients would go to the ICU, then an acute unit or a chronic unit for step down, and then they had the infirmary or self-care unit. And they actually highlight some of their prices for care back then. So the ICU had a 17 to 20 bed ICU, $50 to $80 a day. Now, if you inflation adjust that, it's about 10 times that. So for our current dollars, so it's still about $500 to $800 a day for your ICU care. But what was glaringly absent from this was the emergency department care. So it really wasn't part of the formula for that continuum of care, and they didn't really mention the emergency department at all. And the reason was that emergency medicine really hadn't even been established as a specialty in 1960. And actually, it was not far away in Alexandria, Virginia in 1961 where the first practice of emergency medicine was established. And it's called the Alexandria Plan, where these 4 doctors led by James Mills got together. And back then, again, this will sound very similar to the situation we have now. In 1961, Alexandria Hospital ED was reeling from nearly a 300% increase in patient visits over the past decade. But it was actually, the numbers are on a different scale, up to 18,000 patients. So, we see in our adult ED 75,000 patients a year. Many patients, EDs across the country, see 100,000 patients a year. But that was the problem that they needed to solve, that they had increased volume of people going to the ED. A lot of it was related to uninsured patients at the time. They had a 450 square foot basement ED with 4 stretchers. So it's a little bit different from our system now. So they created a new practice model that these guys were all private practice physicians doing normal private practice. They decided to dedicate their career to emergency medicine. They would do nothing else, which was unheard of. And they would do these 12-hour shifts, 12 p.m. to 12 a.m. or 12 a.m. to 12 p.m. And there was 4 of them covered the emergency department. They would do 5 days straight on and then 5 days off. And that was sort of the creation of the practice of emergency medicine. So they charged $5 a visit, which comes to about $50 a visit in our current dollars. And they actually got a hospital subsidy for indigent care, which many emergency departments in the country have now. So those are the origins. And the interesting thing is that these 2 different specialties were created pretty much at the same time, grew up as twins, but were totally separate. It really didn't have a significant interaction for the early years of both specialties. And just sort of fast forward to this century and what the definitions of these specialties are. If you look at the definition of critical care that comes from the Board of Critical Care, it's the delivery of medical care to any patient who is physiologically unstable, requiring constant and minute-to-minute titration of therapy according to the evolution of disease process. And if you talk to any emergency physician in the room here, they would say that that includes their patient population. And then for emergency medicine, from the ACEP board, practice of emergency medicine includes the initial evaluation, diagnosis, and treatment, coordination of care of any patient requiring expeditious medical, surgical, or psychiatric care. And again, when you talk about the critically ill and injured, that certainly is within the scope of what critical care would claim as part of their work. So the question would be, we have these 2 specialties that got created separately, have a very significant overlap in the patient population, and really the difference has been the location and timing of that care, right? So before emergency departments were well established, a lot of patients would only transiently be in what was the emergency department and go directly to the ICU. And then since then, there's been issues with overcrowding of ICUs and patients spending more and more time in the emergency department, requiring that level of emergency or intensive care. So if you look at that interface between emergency medicine and critical care, it's something that's evolved over time, gone, I think, what I think is from a very separate set of specialties to something that's becoming much more of an overlap and integrated. And I'll just show you some data that would supports that concern. So this is a study that looked at both the number of patients presenting to emergency departments with critical illness and injury and the amount of time that they spend in the emergency department. And between 2001 and 2009, ICU admissions from the emergency department doubled, and from about 1.2 to 2.2 million. So these are patients presenting to the emergency department ending up in the ICU. So the quantity of patients requiring critical care significantly increased. And then that admission rate, the percent of total ED admissions increased from 0.9 to 1.6. So the number of patients per year increased significantly, but also the number of ED critical care hours increased even more. So that 10% per year growth of ED or critical care visits to the ED was a little bit overshadowed by a 24% per year growth in the amount of time critically ill patients spend in the emergency department. So not only were more patients coming in requiring critical care, they were spending a longer time in the emergency department. And when you think about critical illness and injury, one of the things that we've learned more and more over time is time-sensitive diagnosis and treatment has the biggest impact on outcomes. So the sooner you make the right diagnosis and the sooner you apply the effective therapy, the better the outcomes are going to be. And when a greater proportion of those early minutes and hours are being spent in the emergency department, that's probably where the diagnosis and correct treatment needs to be initiated. So, and the other thing is about a third of all ICU patients spend greater than 6 hours in the emergency department. So if those golden hours of care where that diagnosis and treatment needs to be optimized are in the emergency department, we need to be able to deliver that care in that space. And this is just another study that suggests that's really true. So the longer you spend in the emergency department when you're critically ill, the worse your outcome. And this was a study that looked at mortality related to delays in admission to the ICU. If you spent less than 6 hours in the ED before your ICU admission versus more, and mortality was increased by 50% if your admission to the ICU was delayed by 6 hours or more, which was statistically significant, going from 17% if you're delayed to your ICU admission versus 12.9% if it was not delayed. So it just reinforces this idea that for critical illness and injury, that time-sensitive diagnosis and treatment is important in optimizing your outcomes. And Peter Safar back in 1974 really summed it up very well, saying that the most sophisticated intensive care often becomes unnecessarily expensive terminal care when the pre-ICU system fails. So if that initial diagnosis and treatment isn't timely, isn't correct, and isn't effective, then by the time the patient gets to the ICU, a lot of the care that's being delivered at that time may really be unnecessary expensive terminal care rather than care that's going to be effective in improving outcomes. So, based on that, sort of our concept here at Michigan was to really push together that interface of emergency medicine and critical care in a way that we can actually deliver that highest end of critical care the minute the patient hits the door in the emergency department and provide the correct diagnosis and optimal treatment within the therapeutic window of the specific disease. So I got a new logo got the new Michigan Medicine logo and the picture up there. I'll just introduce you sort of the concept of what we initiated when I first got here as chair of the department. And then, like I said, Ben's going to give you a little bit more details of how we moved that forward. So when we came here, the question in my mind was, well, we knew about this problem with critical care and emergency medicine. Was it really a problem here at Michigan? And we wanted to look at that data. And it really was. So this was back in fiscal year 2012. We had 72,000 ED visits. 22,000 of those were admitted, and 2.6%, which was higher than the national average, was getting admitted to the ICU. We see a pretty sick patient population. 5.5 patients a day getting admitted, and our average length of stay was 6 hours. So half of our patients were being admitted before 6 hours, and half of our patients were being admitted after 6 hours. And if you remember that mortality data, that if you're more than 6 hours out, you have a 50% higher mortality, we felt that we did have a problem to solve in our current state. And then if you look at our projected growth of ED admissions to the ICU over time, we were seeing similar to the national average, this 10% predicted growth. So the problem was only going to get worse if we didn't do something about it. So we got together with the directors of the ICU and all the different ICUs in the hospital, got together with Tony Denton and talked about this concept of a disruptive innovation to build an ICU in the emergency department. Staffed by emergency medicine physicians, some of which did dual board certification in emergency medicine critical care, train our nurses to deliver ICU level care, provide the right physician to nursing ratio, and rebuild part of our emergency department that used to be the pediatric emergency department, which got moved over to Mott Children's Hospital, repurpose that as an ICU within the emergency department setting, and then come up with actual care pathways that got initiated in the emergency department and followed through into the different ICUs rather than having a handoff where the care starts all over once the patients get up into the ICU. So this was our guiding principle: create the infrastructure and system necessary to provide time-sensitive diagnosis, monitoring, and treatment of critically ill and injured patients at the University Hospital Adult ED now and in the future. This was the design, and again, this was done, Ben had a huge role, including our whole team, in sort of a lean design of how you would actually build an ICU in the emergency department. And we have 9 beds here, 91 to 99, and then 5 resuscitation bays that are contiguous with that. We had a grand opening on February 16th, 2015 with Dean Williscroft and Tony Denton and Brenda Massey, who was from the Massey Family Foundation, who donated money to support research efforts related to critical care. And that's the EC3, or Emergency Critical Care Center, was named after the Massey Family Foundation. And this is just one glimpse of what the footprint looks like. Each room is really the size of a normal ICU room. We have ability to do dialysis in the rooms. We have plenty of room for ventilators and all you would need to do with critical care. And again, it's staffed the way you would staff an ICU. And it's not just the physical space of having an ICU in the emergency department, but it's really that whole integrated academic mission. So we can provide patient care in the Emergency Critical Care Center, but from an education standpoint, we also developed critical care fellowships tracks for our emergency medicine residency graduates from either here or other institutions to come through and do critical care fellowships either through the pulmonary or anesthesia critical care pathway. We have specific rotations for medical students to come and work in the EC3. Emergency medicine residents get a dedicated experience in that environment, as well as nursing and physician assistants. So there's a whole education scope that's unique in providing critical care in the emergency department. The research opportunities are tremendous. You have a clinical laboratory where you can fill in the gap of critical care research, which is missing, because most of critical care research is done after the patient gets to the ICU, 6-8 hours after the patient has been treated in the emergency department, and either they get excluded from the study or it's too late to do the intervention that we wanted to be studied. So we can enter patients as soon as they're in the ED. We were able to get a K-12 institutional training grant from the National Heart, Lung, and Blood Institute to train people specifically in emergency critical care research. And we're part of a number of national clinical research networks where the EC3 really facilitates patient identification and enrollment and allows us to do sort of really cutting edge clinical trials, one of which we just launched here in Ann Arbor to do extracorporeal cardiopulmonary resuscitation, or ECMO, for patients with refractory cardiac arrest, because we have the manpower and bandwidth to do something like that in the emergency department because of our critical care unit. So with that, and in order to stay in time, this is just some of the team that was really responsible for pulling this whole program together. And I look forward to giving Ben the opportunity to talk about what our experience has been since the EC3 was launched. And I don't know, do we do questions now or after? Or? We can do some now. Okay.
Yeah. One question our institution struggles with is the handoff of critical care from the ED to that destination unit. And part of that is because in our system, patients end up on a variety of different units, and surgery managed unit, medicine managed unit, anesthesia. How are you bridging sort of the ED delivery of critical care with the receiving, and kind of, if you are, starting the communications earlier before the patient goes up?
Yeah, so one of the things we've done just in the process is when we even started developing the EC3, we sat down with the directors of all the different ICUs and said, okay, these are going to be our order sets that we start in. We're in Epic, so we start these order sets in Epic. They get carried through all the way through during their ICU stay. So we got common order sets. We talked about treatment pathways for sepsis, for GI bleed, all those things that we would agree on what the common pathway would be, and we would initiate it in the ED, and it would continue up in the ICU. We're doing some innovative things with the neurocritical care unit in terms of subdural hemorrhage, subarachnoid hemorrhage, even status epilepticus. So getting that agreement up front that we would agree on how we would manage these patients in a consistent way. And then it is consultation, but one of the things that we'll consult the unit that they're going to go to and make sure we communicate with them. But one of the interesting things that we've done to help that break down some barriers is we've been able to get people in emergency medicine who are dual boarded in critical care to spend inpatient time in the different units. So we have on our faculty, so Kyle Gunnarsson does the cardiovascular ICU, Ivan Coe does the medical ICU, Cindy Shude is in the trauma burn ICU, and Sage Whitmore is in the neuro ICU. So we have 4 faculty members that are working in the ED and EC3, but also spend time there. But we also have fellows from the different fellowships come down and work in the EC3. So the anesthesia critical care fellows have a required rotation in the emergency department ICU. The pulmonary critical care fellows have an elective rotation there. So when they've spent time physically down there, they're much less likely to be upstairs sort of having an unreal perspective of what it's like. So those kind of things that at the people level, having people work together, communicate together, I think makes a big difference in identifying the communication issues and addressing them in an effective way.
Bob, can I ask a question? There's a big debate in cardiology right now about whether or not CICUs should be staffed only by intensivist trained cardiologists versus how we do it now, which is you kind of, you think that part of a cardiology fellowship is learning how to deal with critical care cardiology. Is that the model here where it's kind of, do you think that the future is that most emergency medicine physicians will be trained in more critical care, or is it to say that we're going to create these units and have a specific path? I mean, this isn't going to be for every emergency medicine physician.
Yeah. So that's a great question. Our model right now is that we have people that work in the emergency critical care center are either dual trained, so emergency medicine residency, critical care fellowship trained, or have a specific area of interest or focus in critical care and have done so. We had one additional credentialing piece was the Fundamentals of Critical Care Support course that the Society of Critical Care Medicine gives, and there's a certification that comes with that. So we required our emergency physicians to do that, that are working there as well. And really the only difference, the one thing about critical care and emergency medicine is just about everything that you would do in an ICU, we learned to do in emergency medicine, but we only learned the first hour, right? So, on a ventilator, people learn, get someone into bed and put them on a ventilator, but that 6-hour vent settings, things like that, that's sort of not what's typically in our scope, or redosing medications more than once is things that we don't learn or think about. So some of that is extending that duration of care. There are things we don't do, like bronchoscopy. So our board certified people will do bronchoscopes in the EC3, but some of our own physicians don't do that. But then we're expanding the scope of what we're doing for ECMO. So cannulation for ECMO, which again, that's going to be, all the providers will learn to do that. So I don't know if the future would be that you would only have people that are dual boarded. Certainly, the thing I didn't mention about that interface of emergency medicine and critical care, up until 2012, you could not become board certified in critical care if you did a residency in emergency medicine. You could not. So you weren't eligible to sit for the critical care boards through any subspecialty up until 2012, because there was some deal they cut back when emergency medicine became a specialty that we would never provide inpatient care as part of the American Board of Medicine sort of deal. So that got changed, and then there was sort of an influx of people that then were interested in doing critical care. So this is, one option is to do emergency medicine, work in the emergency department, and then work in an ICU. But the other option might be this hybrid form where there's an ICU space in the ED itself to work in. All right.